as we know that there are guidelines which we follow while scanning the fetus in first and second trimester. So ISWAG, we all across the world, everyone is following the ISWAG protocol. So in the first trimester, what we are supposed to see regarding through the fetal kidneys is their presence, whether there are two kidneys are present or absent, and then we should see the urinary bladder where its dimension is less than 7 mm or more, because if it's more than 7 mm, then it becomes a megacystis. Then in second trimester, what we are supposed to see in kidneys is there whether the both kidneys are present, where are they located, is there any associated pelvic cases or not, the urinary bladder, is it visualized or not, how is it appearing, and the amount of liquor, because liquor give the its formation in the first trimester is mainly through the placenta, fetal skin, lungs and membranes, but as it crosses the second extends in the second trimester, the majority of the liquor is being formed by the fetal kidney and urine. So fetal kidneys we can see on ultrasound by approximately 10 weeks of gestation, if we are doing using a high resolution probe, which is a transvaginal probe, and the urinary bladder can be seen by approximately 10 weeks of gestation. And in the first trimester scan, we should all document the urinary bladder, because if the bladder is not seen, then it might be associated with the certain anomalies like exostrophy of the bladder. And for that, if we have a suspicion, then we can ask the patients to get an early target scan done, which we usually advise around 16 to 17 weeks of gestation. So what all the things we look when we are evaluating the fetal urinary system? We should look for the fetal kidneys, the tracts, which is the urinary ureters, then urinary bladder, and the amniotic fluid. It gives a idea about the functioning of the kidney, whether the kidneys are functioning or not. Then before we proceed into the anomalies and the scanning plane, we should know briefly about the embryology. So we all know that from the three-layer germ disc, which usually forms at the third week of the gastrulation of the embryogenesis, which is and from the third week, there is a derivative from the endoderm at around fifth week. Metanephros are formed, and these metanephros, they give rise to our kidneys, and then mesodermic tissue, they form the collective system. So ureteric bud, you can see here, this is the mesonephric duct, mesonephric tissue, hindgut, and these are the metanephric blastema which forms the kidneys, and the tracts are there formed from the ureteric bud, which give rise to the ureter renal pelvis calycis. And its importance is that if there is any duplication of the ureteric bud, it will lead to the duplicated pelvic calyceal system. And the comings to the this metanephric caps, which they are endodermal derivatives, and they interact with the collecting tubule, which is a mesodermal derivative. So their interaction is very important to form the proper functioning of the kidney, which is a glomeruli. So these are the glomeruli with the collecting system. They form if there is an interaction. So if there is a failure of interaction between the ureteric bud and the metanephric mesoderm, so they will lead to there are many anomalies. So that can be an there are various signal associated abnormalities, which could be ARPKD, ADPKD, or there could be a multicystic dysplastic kidneys. Then coming to the position of the kidney, because we all know that the kidneys, it start from the pelvis and then it ascend. So if there is any aberration is in this process, then it will lead to the ectopic kidneys, which could be in the pelvis, or there could be a fusion of the kidneys, which is a horseshoe kidney, or there could be a cross-fused ectopia. So this is the embryological basis for all these abnormalities. So coming to the evaluation of the fetal kidneys, so we usually perform it in the first. With each scan, we should look at the fetal kidneys, because there are certain pelvic cases sometimes which is is in the borderline range, but once you evaluate the fetal kidneys in the second or third trimester, then those kidney the dilatation, it become more evident. So in the first trimester, second, or growth, whenever the patient is visiting at your place, you should look at the fetal kidneys. So there are we should evaluate it in all the three planes. Why it is important? Because in the axial plane, so you can see here, these are the two hypoechoic structures with anechoic renal pelvis. So this is the renal pelvis. You can see here, this is the renal pelvis. In the echogenic rim, this is the wall of the renal pelvis, and this is entire kidney. So in the axial plane, we should store an image of the kidneys at 6 or 12 o'clock position, because in this position only we are going to measure the anteroposterior dimension of the renal pelvis, which is APD. In coronal plane, why it is important? Because we should be able to visualize the inferior margin of the pelvic kidneys, because if in cases of the horseshoe kidney, there will be a fusion across the midline, and a sagittal plane, it gives evaluate the exact extent of the fetal kidney. We should also look for the fetal kidney size, it's like corticomedullary differentiation, or there is any cyst or any lesions which are seen in the kidneys. So you should try to store the images of the kidney in these planes, especially during the anomaly scan. So when we are evaluating the fetal kidneys, what you are supposed to look for. So it is like a adult evaluation of the kidneys as we do for the adult. So what do you do for adult kidney? You see the kidneys where they are located in the renal fossa or it is ectopic. So similarly for the fetus also, we see the kidneys where they are located, where whether they are located in the renal fossa or they are located in the ectopic location, midline, or in the pelvis. Then we should measure the size of the kidney. Sometimes the kidneys are enlarged, and there are normograms available for the fetal size according to the gestational age. But roughly, if the gestation age is 20 weeks, so the size of the kidney should be around 20 mm. So it gives a rough idea that fetal size in kidney fetal size, fetal kidney size in it corresponds to the gestational age in weeks. So if it's 24 weeks, so size of the fetal kidney should be around 24 Then we assess the echogenicity, and we compare the echogenicity of the fetal kidney similar to the adults, like its echogenicity relative to the spleen or liver, whether it's more echogenic or hypo, if its echogenicity is more than liver or the spleen, then it becomes a echogenic kidney. But remember that echogenic kidney we usually do not see in the first trimester scan, because we try to see the fetal kidneys in first trimester scan with use of a high resolution probes, which is a transvaginal probe. So in that cases, the kidney will be appearing very hyper anyways. So try to be very careful that while saying that kidneys to be hyperechoic, you should use this say this term in the second trimester, like around 18 weeks onwards, and you should not be using a high resolution probe to say the same. And then we should look for the corticomedullary differentiation. So this is the medulla, hypoechoic medulla, as we see in the adults, and this is the outer structure, hypoechoic is the cortex. So apart from that, we should look at the renal pelvis, the calyces, whether they are dilated or not, then ureters, urinary bladder, and the amniotic fluid. So this is what we call as a renal assessment of the fetal kidney. All these points we should evaluate. Now coming to the abnormalities. So first we will talk about the renal agenesis. So agenesis means the kidney is not visualized. So what are the signs which can suggest that this is a case of renal agenesis? So directly you will not be seeing the renal kidneys in the renal fossa. So there will be empty renal fossa, and the adrenal will be seen lying down position, with like it is seen. So normally adrenals are seen in the like in upper part, but if it's the kidney is not there, it will be seen occupying the renal fossa and appear rounded and seen in the paravertebral location, what we call it as a lying down sign. And then we can use the Doppler to look for the renal artery. So if in cases of the renal agenesis, the renal artery will not be seen on that side. So renal agenesis, it can be unilateral or bilateral. So unilateral, we often tend, it is missed during the antenatal period because the liquor will be normal and urinary bladder will be seen. But how can we suspect it that in third trimester, when the kidneys are very evidently visible, the normal kidneys, it will appear enlarged. So that can give a clue that if you are not able to see the one kidney and the other kidney is enlarged, then this suggests that there is a unilateral agenesis. Bilateral agenesis, if it is incompatible with life, so there will be appearance of the oligohydramnios after 16 weeks onwards. Why 16 weeks? Because the before that, and I told you that amniotic fluid source is in first trimester and early second trimester is not the fetal urine. It is from the membranes, placenta, and skin and lungs. Um, so oligo we usually see in the late in the like after 16 18 weeks onwards, and also in this case the urinary bladder will not be visualized. So its differential diagnosis for the unilateral agenesis is the, we should rule out the ectopic kidneys. To call anything agenesis, you should thoroughly evaluate the fetal lower abdomen and pelvis, so that this you should not miss the case of ectopic kidneys. And in case of the bilateral renal agenesis, since it is presenting as an oligohydramnios, so its differential includes the early onset fetal growth restriction, because in early onset FGR also there will be a severe oligo. There can be a severe oligo, and if we should ask the mother about the history of the leaking. So if there is any leaking history and liquor will be absent, but in those cases the growth will be normal and the fetal kidney and bladder will be visualized. So whenever you are seeing a case of a severe oligo in the first trimester, three differential, it should click your mind. Is the bilateral renal agenesis, is it a case of the fetal growth restriction early onset, or there is a history of the membrane rupture or leaking history. So now this coming to the case I was showing. So this patient was referred for as a fetal well-being. So you can see here, this is, there is a kidney on the one side. You can see this is a kidney structure. Renal pelvis is seen in this in the center of this hypoechoic structure. So it's a renal kidney, but the other side, the renal fossa is empty, and this is the adrenal gland which is seen in the paravertebral location, what we call as a lying down adrenal. But when we evaluated this fetus thoroughly, what we saw that there was a kidney, the other kidneys was seen as in the lower pelvis superior to the urinary bladder. So you see here it is an urinary bladder, this is the kidney, and it's the renal pelvis is seen here. So when the take home message is that to call any patient, any fetus while evaluating for the renal agenesis unilateral, you should rule out the ectopic kidneys. And the same we saw on the transvaginal ultrasound, because it's very high resolution probe. So you can see here, this is the hypoechoic structure, is the kidney, and the renal pelvis is seen within it. This case was referred to us for second opinion, as the liquor was reduced. So what we saw here, that liquor is severely reduced. The single deepest pocket was 1 centimeter. So and rest of the so you can see here. So when there is a reduced liquor in the first trimester, in the second trimester, or whenever, there are three differences. So we ruled out that there is, it's not a case of the fetal growth restriction. So biometry, it is falling around corresponding to the gestational age. So gestational age was 17 weeks, and all the parameters are roughly around 17 weeks. So when so it's not an FGR. The Dopplers were also normal. So uterine arteries were normal. Umbilical artery is normal. What we saw here is that this is the paravertebral location. So this is the adrenal. So adrenal is appearing rounded. It's not in the top. It has lying down in the paravertebral location, and we are not seeing any kidneys here. So this is the cranial end. This is the caudal end. We are not seeing any kidney here. So this was a case of, you can see here the rounded appearance of the adrenal gland. Kidney is not visualized. The bladder was not visualized. This is the cord insertion, and this is the expected location of the urinary bladder. So normally urinary bladder we see across the wall of the urinary bladder. Adjacent to that, the umbilical arteries courses. So, but here we are not able to see the urinary bladder. So this was a case of the bilateral renal agenesis, which has presented with the severe oligo at 17 weeks of gestation. Now, the renal agenesis, it can be isolated or syndromic. So the two cases that we saw was the earlier case was the isolated bilateral renal agenesis. Now we see the case with the which is associated with the syndrome, and this patient was referred to us for second opinion in view of the single umbilical artery. So there was indeed a single umbilical artery. So this is the urinary bladder. So what I was telling you earlier is that we see the umbilical arteries. We store that two umbilical arteries which is going across, which is coursing along the surface of the, along adjacent to the wall of the urinary bladder. So what we are seeing here is that there is only one umbilical artery. What we saw here additionally is the cleft. So uh, this is a fetal face section which we have taken. So this is at the level of the maxillary alveolus. So this is the alveolar process of the maxilla, and this is what we are supposed to see is the posterior edge of the hard palate, but there is a defect. So there is a cleft of secondary palate. Eyes are very small. You can see here this eye is very small. So there is a micro-ophthalmia. Apart from that, the ears were normal. And what you can see here is that there is a retrognathia. So this chin is positioned posteriorly. So there is a component of the micro and retrognathia. This is the 3D image to show the same, that the chin is positioned posteriorly and it's appearing small. So, and also what we saw in this patient is the aberrant right subclavian artery. So this is the arch, and this hypoechoic structure with echogenic rim is trachea, and the subclavian artery is coursing posterior to the trachea. So there was an aberrant right subclavian artery, and what we saw in the kidneys is that this is one kidney, but other side this is the hypoechoic structure is the adrenal, but we are not seeing any kidney like tissue in this region. These are the echogenic bowel. So there is a component of a unilateral renal agenesis as well. So this is the adrenal, and the adrenal is in the paravertebral location, lying down adrenal sign, but the other kidney is not visualized, so one side kidney is seen. So this was a case of a unilateral renal agenesis, which is associated with this multi-system anomaly. So this is more likely to be a syndromic, and this patient terminated the pregnancy without getting any genetic testing done. Now coming to the horseshoe kidney, so it's a common fusion anomaly. And how do we suspect it while anomaly scan? As the kidneys are medially and anteriorly rotated, so we can suspect it on the axial plane as well as in the coronal plane, and uh, it is associated with the other anomalies such as CNS anomalies, cardiac and skeletal. So detailed, thorough evaluation of the fetus is mandatory, and there is increased risk for trisomy 18 and Turner. So invasive testing is recommended. So you should suggest ask them to get at least karyotype. If not, they are getting the chromosomal microarray or NIPS depending on their affordability. So this patient was referred to us for anomaly scan. So you can see here the normally the renal pelvis is positioned parallel to the surface horizontally, but when there is a horseshoe kidney, we can see here that the direction of the renal pelvis is anteromedially. So on the axial planes, so um, when I was talking about the different planes, so you can see here normally how it is located, how the renal pelvis is seen. It is oriented parallel. So like this, it is oriented in this axial plane. This is the renal pelvis. But if it's a horseshoe kidney, it will be seen uh, directed medially, anteromedially. So this is the renal pelvis which is directed anteromedially. So, when there is such orientation of the fetal kidney, then we should suspect that there could be a horseshoe kidney, and we should evaluate that fetus kidney in all three plane to confirm our finding. So, we took the coronal section, and you can see here the inferior poles of the both the kidneys are fused across the midline. So, it's a case of a horseshoe kidney which we confirmed on the coronal plane.